Annabelle Stevens is a PhD student at the Kirby Institute, University of New South Wales, and is the manager of the Hepatitis C Policy Unit at New South Wales Health. Annabelle is passionate, I'm reading this. Annabelle, did you write this? Is passionate about using research to inform policies and improve healthcare access and outcomes, and is presenting on the prevalence of hepatitis C infections among people receiving point-of-care testing at community services in Australia. Welcome, Annabelle. Over to you.
Thanks so much, Margaret. And thanks so much for having me today. I'm really excited to be able to provide some data on our national hepatitis C point-of-care testing program. Before I start, I do want to acknowledge the traditional owners of the land on which I live and work, the Gamaragal people of the Eora Nation, and pay my respects to elders past, present and emerging. And I have no disclosures. So in Australia, we've made some really substantial progress in getting closer to elimination of hepatitis C, particularly among people who attend needle and syringe programs and other key population groups. You can see on the graph here on the right that RNA prevalence has dropped from around 50% in 2015 to around 10% in 2023, and that's in our Australian Needle and Syringe Program survey. But despite some really great progress that we've made, there are still almost 70,000 people living in Australia with hepatitis C, and traditional services such as tertiary clinics and primary care may miss people who are most at risk of infection due to different structural and patient barriers to engagement in care. So we need real-world data on who's left, where are they, so that we can understand prevalence among different population groups and hopefully achieve elimination of hepatitis C. So the aims of this study were among people receiving point-of-care testing in the Australian hepatitis C point-of-care testing program between 2022 and 2024. We looked at evaluating the prevalence of hepatitis C antibody and current hepatitis C infection, and then analysed factors associated with antibody and current infection. We looked at the analysis of this by different community types and different subpopulations, and we're hoping that this analysis will help inform targeted testing and treatment strategies. All right, so just a little bit of background about the National Australian Hepatitis C Point-of-Care Testing Program. Participants are recruited from all states and territories across Australia, as you can see in the map here. At the end of July, we had 114 participating sites at 510 testing locations, and we'd done over 47,000 tests. You can see that the participating sites are quite a range of different services, but all services that provide care to people at risk of infection. So we have drug treatment clinics, needle and syringe programs, prisons, mental health, mobile outreach, homelessness and Aboriginal services. And the inclusion criteria in the national program is 18 years of age or older, and either being at risk of hepatitis C or attending a service providing care for people at risk of hepatitis C. So testing in or inclusion in the national program is now based on prior self-reported hepatitis C status. So those who have never been told that they have hepatitis C before receive a point-of-care antibody test, either with the INSTI 1-minute test or the BioLine Abbott 5-minute test. And if they're antibody positive, they are reflexively tested for RNA with the Gene Expert Cepheid 60-minute test. Those with prior exposure to hepatitis C receive immediate point-of-care RNA testing with the Gene Expert. And those found to have current hep C infection are also offered HIV testing with the Alere combo and hep B surface antigen testing with the Alere Determine. So our statistical analysis included participants enrolled in community settings between the 1st of January 22 and the 31st of December 24. We looked at baseline characteristics and stratified it by the community setting type where the test happened. As not everyone had an antibody test, we had to estimate antibody prevalence based on either their antibody result if they had one, their RNA test result, or their self-reported history of infection. And we use logistic regression to evaluate the patient factors and the setting types associated with infection. Those included age, gender, Aboriginal or Torres Strait Islander background, history of injecting drugs, history of incarceration, and history of OAT. And here's a flowchart of the analysis in our study population. So at the end of 2024, we'd completed 38,249 tests, including 14,500 in community sites and almost 24,000 in the prisons and minimal data sites. But we're not including those in this analysis. So among the community sites that we're including, some people had more than one test, so we had 11,575 people enrolled. And among those with a valid test within 30 days, 40% were found to be antibody positive and 8% had current infection. All right, so just looking at the baseline characteristics now of our study population, the graph on the left shows the distribution of participants by their state or territory, and the baseline demographics on the right are of the participants. So among those tested, 38% were female, the median age was 44 years, just under half had history of incarceration, 23% were on OAT, and 31% had reported injecting drugs in the last 30 days. Okay, so now we're getting into the meaty stuff. So this graph looks at the antibody prevalence of our study population by their patient demographics. We conducted an adjusted logistic regression model, and you can see the adjusted odds ratio on the right. The dotted line is the mean antibody prevalence here, which was 38%. And you can see that those patient demographics with a higher likelihood of antibody prevalence were those with a history of injecting drugs, with an adjusted odds ratio of 26.67, people currently on OAT, and Aboriginal and Torres Strait Islander people. And then this is antibody prevalence by the site type. So we're looking at, again, adjusted logistic regression, but we adjusted for age and gender here. And just flagging, this data is still preliminary. We're firmly and quickly working up the paper, but just checking what's in that sort of other category and see if we can sort of find out a bit more information about those setting types. But those key settings with a higher antibody prevalence were drug treatment clinics at 62%, and needle and syringe programs at 52%. And those settings with a lower prevalence of antibody were mental health services and Aboriginal health services. This graph now is looking at current hepatitis C infections, so they were RNA detectable on the Gene Expert. Our overall prevalence was 8%, which is pretty in line with other Australian research that we've seen among key settings. The highest group, or the group with the highest likelihood of current infection, were those with a history of injecting drugs, and those currently experiencing homelessness. And then again, looking at those that were RNA detectable by their site type, we saw a higher proportion among needle and syringe programs at 12%, and a lower proportion among drug treatment clinics at 10%. Drug treatment clinics were also high. Lowest were mental health services and Aboriginal health services. You can probably see that on the graph better. So then we also wanted to have a look at what was the prevalence of current hepatitis C infection, so RNA detectable, among those people with exposure of hepatitis C, so this estimated antibody prevalence. And this helps us to consider treatment uptake and engagement in care at enrolment. So the overall prevalence of this category was 23%, and it was higher among those currently experiencing homelessness and those not on opioid agonist therapy. But interestingly, we saw that those who were currently on opioid agonist therapy had reduced likelihood of hepatitis C among those with history of exposure. So despite OAT being a risk factor for hepatitis C RNA and antibody in our previous analysis, this lower proportion here might suggest that people on OAT have greater access to services and are linked into care, and so may be receiving care more so than some of these other patient demographics. And then again, looking at the prevalence of infection among history of exposure by site type. And you'll probably notice pretty quickly that we are seeing potentially a bit more equity across the site type. There is pretty similar prevalence across the board. There is still more to do, but in particular, we want to look at those with a lower prevalence to sort of see what's happening here. So drug treatment clinics have a lower prevalence at 17%, and although numbers are small, mental health services had a much lower proportion at 7%. And although this wasn't part of the initial analysis, we wanted to put some treatment uptake numbers in there too, just to sort of finish the cascade of care in a way. So again, we're seeing quite similar spread across treatment uptake within 12 weeks of the Gene Expert test. And lower proportions were among people who were currently homeless with an adjusted odds ratio of 0.7. So unfortunately, that really does highlight where we need to provide better access to care. And then treatment uptake by setting type. We're seeing a higher proportion among those people tested in probation and parole settings, and lower in needle and syringe programs and community outreach. So one thing to remember about the national program is that this does include an in-reach model. So those sites that might not normally offer care would have a service come in and provide testing. So in those cases, they may need to refer people elsewhere for treatment, which may have an impact on treatment uptake. All right, so pulling it all together now, we found that there were differences in hepatitis C antibody and RNA prevalence by subpopulations and setting types among people tested in the Australian hepatitis C point-of-care testing program. Particularly looking at this idea of people with previous exposure to Hep C, we saw a 25% prevalence, or 25% had current infection. Looking at patient demographics, people experiencing homelessness had a higher proportion with current infection, and people receiving OAT had a lower proportion. And then by settings, people in mental health and drug treatment clinics had a lower proportion with current infection. And then looking at treatment, so among people with current infection, 51% initiated within 12 weeks. Homelessness was associated with a lower proportion initiating treatment, but treatment initiation was higher in probation and parole settings and lower in community outreach and needle and syringe programs. So what we found is that there's been fantastic progress towards elimination in Australia, but there are still gaps that remain. We found that potentially structured environments such as drug treatment clinics and probation and parole services may support better follow-up and treatment uptake. We should be integrating testing as routine care into high prevalence sites such as needle and syringe programs and drug treatment clinics, and target testing into low prevalence settings such as mental health to those at risk of infection. And we should also consider tailoring strategies to either setting specific barriers or enablers to support enhanced treatment initiation in a range of settings. And just want to thank all of the people that are part of the national program. This is a growing list. Without them, this work couldn't happen, and also the very large team from the national program. Thank you.